This is Ryan Yousefian. This is Dr. Joseph Yousefian's son. Ryan works closely with his father. Um, Ryan, why don't you tell us to what capacity do you work alongside your dad, Dr. Joseph Yousefian?
So, aside from being the guinea pig for everything that he's done, I work with his practice a little bit. I do more just like surface level marketing stuff and just practice management. Outside of that, we run ApnoMed. So that's kind of our project together, our business that we run. Um, he's mostly consumed by his practice, obviously, right? He's a full time clinician still. But out of that, we're usually working on ApnoMed, doing a lot of R&D. Um, and then out of that, we also run comprehensive treatment seminars, which is our study club, which I think, Ron, I've sent you a couple of the sessions to listen to, the good ones that I think are beneficial for you.
Mm-hmm.
But those are kind of the three roles that we work together. So it's been a fun journey together. We do butt heads sometimes, as you would expect, but I
Yeah, of
wouldn't trade
course.
it for the world.
For sure. Yeah, I work with my dad in a business too, and it's inevitable to butt heads, but at the end of the day, it's such a precious gift to have that
It is.
opportunity.
It is definitely, especially with what we're doing, impacting and touching lives every day. Sometimes we sit back and look at it and I'm like, this is so, I wouldn't trade this for any salary, anything else in the world, because I can look back at this in life and say, we really did something meaningful together. And not that many father and son like yourself get to venture down that path with each
Yeah.
other. So it's a pretty cool experience.
Yeah, can you think of like a particular case that you're thinking of where someone's life was impacted and they were sort of rescued from the despair of sleep apnea?
I mean, myself, we'll talk about that. Other than myself, every single day in his office. I mean, you see patients that will cry because my dad's practice, which you've talked about him a lot on your channel, 96 to 98% of his patients are miserable, in pain. They have been tossed around to various providers. They've probably been in ortho one or two times. So they end up at his office, and he listens, right? The first thing that people say about him is that he actually listened to me and didn't tell me it's in my head.
Hmm.
That's what people are told a lot, whether it's even an ortho issue or out of that. They have some weird issues going on. They've been to naturopaths and homeopathic medicine, whatever. People tell them they're exaggerating, it's in their head. But my dad is a very innovative, as much out of the box as it gets, I think. So when he hears these things, his brain starts, gears start turning, and he starts connecting the dots. I mean, you've read his case, his consult reports, exam reports. They're very in depth. I mean, everything that could cause something will be in there, whether it's a dietary, an allergy, right? A lot of his patients will get a sensitivity test. If it's gluten, eggs, dairy that's causing inflammation, this is something you've even talked on your channel. Dietary inflammation can cause upper airway resistance issues if everything's
Hmm.
inflamed. So back to what I was saying with him
Can I
is,
can I
yeah,
interrupt for a second, Ryan? So
yeah,
when I tend to characterize your dad on my channel as the guy who does a mandibular expansion, right?
yes.
Do you think that's selling him short? And like, is that too simplistic? Like, what else would you say about your dad stands him apart from other top providers besides just doing mandibular skeletal expansion to coincide with MSE?
He really cares about his patients. I know my dad better than anyone, but I know that there isn't a single moment of the day where he's not thinking about a case or a certain patient. And just whether it's 3 in the morning in his bed, waking up and writing down an idea he thinks that's wrong with that patient, but his patients are his life.
Mm.
And he's dedicated everything that he does every day in that office. And if it's not good or it'll cause harm or whatever it may be, I know that he's not going to do it.
Hmm.
But he's not looking at it in a closed box perspective, right? I mean, as I told you, I don't know many ortho guys who are prescribing food sensitivity tests. Maybe I haven't met that provider that does that. But I mean, he's looking at lifestyle habits, hereditary, what's in their genetics, what does mom and dad look like, what does grandpa and grandma look like. But I think that all stems from his background, his education, what led him to the ortho realm. But I mean, he's diagnosed cancers, he's diagnosed brain tumors in patients. So he's not just looking here. It's more of, a head to toe, because as much as if this is out of sync, the body is out of sync, right? This is kind of our computer system, right? You get patients who come in with a hobble. The chiropractor tells them they've got asymmetry in their hips. Their shoulder is this way. Well, I mean, if you got imbalances there, I bet you more than likely it's because something up here is canted and it's causing their body to autocorrect everything. So it's a very comprehensive approach that he does in his practice. And I think that's kind of what separates him from the rest.
Yeah, another thing I've noticed about what your dad does is he diagnoses a lot of TMJ disease.
Oh, yeah.
Where
That's
I never see any other orthodontist, because I see a lot of treatment plans, because I offer one-on-one chats. People reach out to me to get my opinion for whatever it's worth, and they send me what the doctor has written for them. Your dad is the only one that I ever see diagnosing I forget what the conditions are called, but like basically degenerative disease within the
yes.
temporomandibular joint. He's always looking for that and having patients go out and take extra tests to make sure that the joint is stable and not, what would the word be, degrading or eroding or resorbing.
Yeah, condylar resorption.
Yeah.
So my dad, he's a TMJ guy. Bread and butter is TMJ. That was his specialty, was TMJ. He's a pain guy, right? So when he started his practice, he was the person for TMJ treatment and resolving it, which is what makes him such a good sleep apnea clinician, because he understands the joint. People who don't understand the joint, I'm not quite sure how they can really address the airway. Because if you look at how sleep apnea, obstructive, right? We're talking obstructive here, not essential apnea. We're talking obstructive, upper airway resistance. I'm going to go out on a limb, Ron. I'm going to say I think 99% of patients who have some sort of an airway discrepancy will always have a joint issue. They always go hand in hand. Why? Well, let's say a patient comes in, they say, I have clicking and popping, I clench and brux at night, I have severe pain, headaches, my neck, I have a stiff neck, I have chronic migraines. Well, what is the body's first line of response to an obstructive airway, a collapsed airway? It's to bite. That is the only and first line of defense the body has, because when you bite, what does it do? It tenses up all the muscles and it stiffens up the airway. So if you look at an airway patient who has severe apneic episodes, and then you look at their sleep report, there's almost always a clenching bruxing at the same time. So I think if you look at airway patients, they more than likely always have a TMJ, bruxing, pain, degenerative condylar resorption. On the other end, if you have a patient that just comes in for TMJ pain, more than likely they're going to have an airway discrepancy. And I think that's what makes him very unique, because he's a master in both of those realms.
Right. Now, I know that you're not the doctor, but let me ask you a question about why that is. So when you bite down and you brux to open up your airway, does just the excessive biting cause the condylar problem?
Yeah.
Or is it that they bite in weird
Yes.
orientation? As like, do they jut their lower jaw forward to try to open the airway that way too? And then you end up biting at a bad angle, which exacerbates the TMJ disorder?
Again, I'm nowhere near qualified to even make a diagnosis or give my opinion on this, but from what I understand, that every time you even bite or whatever you do, it is micro trauma on the joints, right? It's just like a runner's knees, right? Every step they take, yeah, if they're not running in perfect form in a perfect environment, every time they impact, it can wear and tear on that knee, on that joint. So it's the same thing in the TMJ, but you're looking at such a tiny little joint that can put so much pounds of pressure on there, right? And when you look at bruxing, especially an airway episode, I mean, it is severe force that's being put on that. So that's when you get into then over the years, when you get into condylar resorption, is literally the meltdown of the condyle. Well, when the condyle melts, and I can tell you handful of patients in our office that we see, that condyle is literally almost in the brain. It has gone through the skull, and you can pretty much see it. It's inside. That's how far that it wears through the joint, right? So then what happens? The mandible retracts. What happens when the mandible retracts? The airway gets smaller, the tongue goes into the back of the airway. It's a snowball effect, right? So if you get these clinicians, when I said I don't understand how a clinician can truly address an airway issue without understanding the joint, let's say you resolve a patient's issue with their airway, you do MSE, you do all of this stuff, but they still have TMJ. It's going to be a matter of a couple years, 10, 20 years in their elder years, where that mandible is still going to retract because their bite is not in an optimal position and that joint is still compromised, which is where the joint degradation comes in, everything retracts, and then you're pretty much back or worse to where you started.
Wow, man. Wow. You know, the more
I'm not I'm not a clinician. This is just my knowledge of growing up in a chair with him. But you know, I think that's what you should talk to him about is more in depth because that is his expertise is the joint.
Yeah. It's actually really discouraging to think of how delicate the whole system is and how slippery the slope is to end up on a highway to hell with regards to this snowballing airway TMJ degradation into a total breakdown
Yeah,
of your face and body. It's almost like God made this part of our body a little bit too fragile. You know, I feel like it's been too easy for humanity to slip into this epidemic of health destruction via our faces.
yeah. I think my take on this, Ron, and I think you even have touched on this, is it's not so much design flaw, it's environmental factors and epigenetics, right? You look at industrialized countries, soft food diets, they're not breastfeeding anymore. Thumb sucking, right? Not eating hard, dense foods, chewing, developing masseters. That's what's causing most of these issues to happen, right? And that's something that you also are aware of. So,
Yeah.
but yeah, I mean, it is such a delicate joint. Obviously, it's tiny, but yeah, I mean, it is. If you've read his reports, you've even had patients go over it. There's always a TMJ diagnosis in there.
Yeah.
Always.
Yeah.
Actually, his treatment starts with this,
Hmm.
and then ends with this in the airway. Always.
Hmm. I feel like I wish the human body was the facial joints were made as more of a diesel engine than like a gas engine, and that they
Definitely.
were more durable because like it's just been too easy for all of Western civilization to succumb to these environmental uh, 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 pitfalls that have caused all of this morbidity.
Yep.
You know,
I
it's
mean,
frustrating.
you look at United Kingdom, United States, China, right? I believe those are the leading industrialized civilizations right now with the highest rate of oral cavity airway discrepancies.
Hmm.
So, you know, fast food diets, they're drinking smoothies and milkshakes, right, for breakfast. So there's just so many factors that go into it. But it is horrendous. And I think that you're starting to get the common theme of this space is that like we have scratched the surface of really what's going on. People freak out about coronavirus and epidemics. We've got a silent killer that nobody is really. The news doesn't talk about it. Physicians don't screen for it. Dentists don't screen for it. Very few even know what it is. People think you just snore. You know, it's snoring. Now, snoring isn't always associated with obstructive apnea, right? Because snoring is just vibrating of the soft upper palate. But usually they go hand in hand. And it's a movement. You know, we need to create like you're doing, Ron, is educating people that your snoring could be killing you. And people don't understand that. They take it very lightly. You know, but you tell a man, which is funny because in our office, either patient comes in because the wife can't tolerate the snoring anymore, so they send their husband in,
Hmm.
or they're borderline dying and they need help, or they can't get a boner. That's what men care about,
Yeah,
right? But
yeah.
they don't understand that that is probably because of their airway discrepancy. So typically, when we tell patients, you know, do you have impotence? That's when they're like, yeah, why? Well, you're not sleeping at night. Where do I sign? How much is this? I don't care. So,
Right, right. What's the connection there?
well, I mean, if your hormone production is at night, right?
Right.
Specifically in the REM sleep. So if you're not in that deep REM, your thyroid, your hormones are not producing levels and your testosterone, I mean, just
Hmm.
down. And then that means no sex drive.
Mhm.
So there's a direct correlation there.
So how do you feel about the fact that this problem is so widespread and top tier providers like your dad are one in what, 7 billion? I
Yeah,
mean, are we really headed in the right direction here?
I hope so. I think you're the right direction. I think people like you, people like my dad, people like Lipkin, people like Dr. Moon, these are all pioneers, right? They're like the Michelangelo, the Da Vinci's, man. I think this is going to be history that's going to be written for these guys who went against the norm and took this step to do something that people thought were wacko. I remember when my dad came out doing this stuff 10, 15 years ago, they thought he was a straight up lunatic. He used to teach at the University of Washington Dental School, which is the best university we have in Washington. That's where I got my master's. And he was told to leave that school or stick to their curriculum if he kept talking about his philosophy. And guess what? He did obviously was leave because he knew it was a huge mistake. I still think the industry as a whole is probably 15 years behind. You know, what we're talking about right now, I think we're 15 years ahead, is what I'm trying to say, from the rest of the understanding of even, man, the physicians I talk to. They have no clue about anything oral cavity related. If you tell a physician an ENT about airway, they're going to tell you to either cut your palate, do some sort of a surgery, or cut your tongue, right? And I'm opening a whole can of worms here, but I think a big problem, Ron, is the disconnect between the medical community and the dental community. Because sleep apnea is what? It's a medical condition. But where does it occur? In the dental side of the house. So you've got medical guys trying to treat a dental condition. Two plus
Right,
two equals five in that world, right? It doesn't make
right,
sense.
right. How in the hell did dentistry end up breaking off from medicine anyway? Why isn't dentistry just one of the specialties you can do as a physician? And
Oh,
I think it's because dentists, their bread and butter is drilling and filling caries, and yet that somehow boxed dentists into this, you know, the whole mouth and everything associated with it has been assigned to dentistry, but dentists primarily are trained to drill out cavities. And
yeah.
so everything else that's related to the mouth, such as TMJ disorders and sleep apnea, is totally neglected. And dentists are only doctors aren't learning about it because it's in the mouth and there's no medical specialty that has to do with the mouth. That's dentistry. But then dentists are only learning how to drill and fill, and they're only able to become experts in TMJ issues and airway issues by taking continued education classes, right?
I have no idea. I don't have an answer for you on that one. But it is the biggest issue that I come across, even with our ApnoMed providers, right? When they get started, they feel discouraged because they think that it's not their job. It's not their specialty. They're not smart enough. They need to leave it to the physicians. And my opinion is that it's the complete opposite, right? Who should be doing the diagnosis of an airway discrepancy? It's a dentist. Who do I see twice a year on a regular basis? It's my dentist. They look in my mouth the most. I've my physician that I see once every 2 years now, you look good. That's literally, he puts that thing in your mouth, goes, you go, yeah, you look good.
Yeah.
Little do they know that constricted arch with the tongue patterning and, pulled out teeth, four bite extraction, that patient is probably a ticking time bomb. And they literally have no clue. They don't understand that space. So I don't know how to answer that question that you asked. It's a really good question. I don't know where the disconnect happened, but it's kind of like an elitist thing. I think the physicians and surgeons, they think they're the hot shit. But really, it's the dentists who are the quarterbacks. That's what my dad preaches. The dentist, not even the ortho, the dentist should be the quarterback who is strategizing the entire treatment approach because dentists see more people than anybody, than an ortho, than an ENT, whatever it is, because people need teeth cleanings, they get cavities, they're going to go see their dentist. That dentist should be screening 20 minutes in a chair side, not even, that's exaggeration, 10 minutes. They can go through a sleep questionnaire, do an oral cavity examination, and based off of how the patient is looks or has chief complaints, that dentist should be able to say, hey, Ron, I think that you are at risk for having obstructive sleep apnea. I'm going to send you to the sleep doctor for a sleep test, right? Once that sleep test comes back positive, that dentist is then going to decide, I need you to go see this ortho, who is then going to do some expansion or treat your constricted oral cavity. That ortho is probably going to use the oral surgeon to install TADs, to do surgery, whatever needs to be done. So it's a team approach. There's too many freaking egotistic doctors out there who cannot just step away from their high horse and admit that they can't do it all themselves. Right?
Yeah.
It's Rome wasn't built in one day by one person. It was a team effort. And that's kind of what my dad preaches and what Dr. Simmons preaches, what all of these doctors who are on the top of their game, they understand that they need the good dentist who needs the good ortho, who needs the good oral surgeon, even naturopaths, dude. I can't tell you how many cases my dad works with a naturopathic doctor because they're willing to step out of the box and do stuff that the physician doesn't want to test for, like a gluten intolerance or a dairy or an egg sensitivity. Like that's real shit, man, that people just goes over their head,
Yeah, the problem really does come back to a failure in our healthcare system.
100%.
The medical school curriculums are ass backwards.
Yeah.
I don't know what they're teaching, but they're not teaching about the big elephants in the room that are plaguing Americans and Westerners. They're just not. And it's not that complicated. Like we're not talking about, genetics and cancer genes and, invisible stuff that you can't see without a microscope. We're talking about the volume of a box in someone's face.
Yeah. This is all a can of worms, my friend, but I like opening these and diving into them, but it's almost sounds like a conspiracy theory. Yeah. Because you look at the pharmaceutical industry, they thrive on sick people, right? If sick people stop, pharmaceuticals, which is a multi-trillion-dollar industry, is down the drain. Okay, so you look at cancer, you look at heart disease, diabetes, you look at now sleep apnea. Okay, patients who have sleep apnea, they're at exponential skyrocket, likelihood to have these medical conditions. Yeah. Well, why would then these political, people who are involved in pharmaceuticals want sleep apnea to become a more relevant topic? Because if they get rid of those easily, like you're saying, it's not a rocket science. Stop pulling teeth, promote, forward jaw growth, better tongue posture, early things you can do to encourage kids to grow into a proper arch and mandible development. These are very easy things, but then you have less sick people, which means less money being made on the medical side of the house, less pills, less Adderalls. You've got ADD. Everybody's got it. Let's just put everybody on amphetamines. Makes money. So it's sickening. And I don't know if or when it will change. I don't know if it's my lifetime or whose lifetime, but when you start to really look at the bigger picture, it kind of makes your stomach churn because it's sickening.
Mm-hmm. It's very sad that the only people who are getting help are the ones that are either intelligent or lucky enough to stumble upon, my channel or similar content online.
Yeah.
Or kids that just so happen to be geographically located near doctors like your dad, who their mother Googles orthodontist near me and just by luck of the draw chooses to go visit your dad instead of, Dr. Bozo the clown down the street who's going to chuck her kid's teeth.
But here's the problem, Ron, is that patient comes in, somebody like my dad or whoever diagnoses, opens their eyes to airway issues. And, my dad's looking at the mom, severely overweight. She can barely breathe while the kid is sitting there, right? And starts to tell them that, you all suffer from this. Now he sounds like a lunatic because they've never heard of it. And then guess what? They go to Bozo the clown doctor, who's also an idiot, and says, no, what are you talking about? I'll give you Invisalign for $3,000. I'll straighten your teeth. Yeah. You don't have airway issues. Your kid is skinny. There's no way.
Yeah.
Man, we see it every day. And then guess what happens? That kid comes back in 10 years and he remembers that there was a guy who told him he had all these issues. And now the kid is in their early, development years. They're suffering. And now they're back in his chair having failed ortho once or twice. So I don't know, man. It's it's like chasing your tail, whatever you want to call it. But
It
I
gets
see it every day.
it gets down to an even more core problem, which is people's ignorance and people's lack of self-awareness and lack of bodily awareness. Everyone is so numb now to their own illness. People are so clouded with media and drugs and shitty food that
Yeah.
makes them feel crappy all the time, that they don't even know the difference between feeling crappy and feeling healthy.
Yes.
So they don't have the intuition to be able to discern how sick they actually are. You could tell them they're sick, you could show them a scan that proves that they're sick, and they still won't believe you.
Yes.
So
I know.
one thing I've noticed about the people who reach out to me to chat is that they're all very self-aware. I would even say that most of them are so-called HSP, highly sensitive people, who are, if they eat the wrong thing, they feel it, right?
Yes.
Or if they take a medicine, they feel it. Or if they have a bad night's sleep, they feel it. And they're also very intelligent. So they're able to work through this web of misinformation and stupid mainstream medical advice to arrive at the truth. And it's just it's a small percentage of people that are going to make it through that gauntlet and
Yeah.
realize what the problem is and then seek the help, which I guess is it's just Darwinism, I guess, right? It's the way it has to be, because otherwise your dad would have what, 1 million patients in the
Yeah.
Seattle area who wanted to see him, but instead it's probably a couple of thousand who figured it out and reached out to him.
Yeah. I mean, it's oh, here comes the dog. It is troublesome, and it's what keeps me up at nights, and I think it is literally accidental. I think, like you said, like, I'm sure how you got into all this was a total dumb luck accident, and it opened your eyes. So I think that's where we're at right now. But I think the only way forward is to just keep pushing and doing what we're doing. I'm very confident that, our ApnoMed providers, they're screening every patient. I know they are. So it's just how well can we educate doctors and give them the right tools to give the best treatment to their patients. But I really do think, educating just general dentists, I think that is going to have an astronomical impact on how we move forward as an industry, because there's over, I think around 250,000 licensed general dentists in the US. I think the amount of ortho guys is like 15 to 20,000.
Mm.
So if you look at, getting to the masses in front of the most patients with health issues, it is going to start at the general dentist, because there's most of them and they see the most patients on a regular basis, whether it's for a cavity, just teeth cleaning. So that's really, like, with ApnoMed, is our focus, is educating general dentists to identify the issue and then start that treatment path, and then find the ortho in their area, ortho guy who can do expansion, find the oral surgeon, whatever it may be, sleep doctor. So
Yeah. So how's that all work? So you guys run seminars, and how do general dentists find you and decide to take your
it
course?
depends. Yeah, some of it is because what's unique about our appliances is the limiting side effects, right? So the way that the ApnoDent and ApnoTX were designed, they actually started off as splits and night guards that my dad was using in his practice on TMJ cases. That appliance, obviously, the core function of it was joint stability, right? Cause no harm to the joint or the bite. And then that morphed into a sleep appliance. So I don't have one here, unfortunately, but it's a single arch appliance, which means it only goes on the upper teeth. With other oral appliances, let's say a Herbst or a dorsal or a mite or a tap, whatever oral appliance you look at, they typically attach to the upper and lower teeth and use the upper teeth as leverage to bring the mandible forward to open up the airway, right? That's where you get the long-term side effects, which can even be short-term. It can happen in a few months. Permanent tooth movement, bite change, and severe joint pain because of how they unnaturally anchor the mandible forward using the teeth as leverage, which is what we know now as headgear effect, right? We now know that oral appliances have a similar effect on the upper as headgear, which can retract over years of use. So what's
Wow.
unique with ApnoMed and ApnoDent, if you're looking at our sleep appliances, not our expanders, is that we do not anchor on the upper teeth to bring the mandible forward, we kind of utilize the body's mechanosensory activation, which is a tactile response. And any of your customers or viewers who have used an ApnoDent, they're going to understand what I'm saying. But there's just a bar on the lower part of the appliance that adjusts forward. When the lower teeth touch that bar, it's really telling the brain that, hey, your mandible can't go farther back. Let's actually, on our own muscular force, hold it forward and bite down on the appliance. So that's why, again, we've had no bite changes yet. But what drives clinicians to us is typically two factors. Is one, they've experienced side effects on their own patients, and they still want to provide a sleep treatment to their patients, but they're scared, right? There have been several lawsuits against oral device companies for causing side effects. So they kind of get weary. They don't want to go down that rabbit hole. But then we're going to them and saying there's a safe solution. Your patient can sleep at night, manage their TMJ and airway, and you don't have to stay up at nights worrying if that patient's going to come back in 6 months with a whole crap load of issues. The other half of it is actually patients who will go to the doctor and say, hey, they're kind of like progressive patients. They're like the early adopters, like a lot of your viewers, right? They identify they have an issue. They've done their research. They don't want to wear a CPAP. They want an oral appliance, but they don't want to get the side effects. So they go then tell their clinician that, hey, I want this appliance. The provider reaches out to us. We get them trained for free. They order the appliance. And then on top of that, we also do seminars and courses, like comprehensive treatment seminars, where we teach them, we give them the tools. And that's pretty much it. It's really not rocket science at all.
Yeah. So would you say that most of the appliances that you're distributing to general dentists are, would you call it a splint? Is it a splint? Not really, right?
No, most of the appliances that are used right now is the ApnoDent. That's just a long-term management appliance. It's not to be used in an active orthodontic case like you see in my dentist office. He almost rarely uses the ApnoDent because when a patient comes in, they're going to go through treatment and they need a passive appliance that they can use throughout that treatment, which is the ApnoTX. But yes, it would be the ApnoDent, which is really, it's a FDA cleared oral appliance for sleep apnea. But it's really, if you look at it functionally, it really acts like a TMJ splint because you can adjust the occlusion of the appliance, whereas you can't do that with other oral appliances. So it means the bite, if you have an unstable bite and then you shove an appliance in that patient's mouth, it's just going to make it worse because you're yanking their mandible forward and they're still biting down on a non-perfect occlusal surface. Whereas with the ApnoDent, when the clinician delivers it chairside, right? I don't know if you've ever gone through getting a splint or a night guard, but they have you bite wax paper and then they shave off the acrylic to make sure that your bite is perfectly symmetric so that the joint is biting down evenly and it's safe on the joint. So that's how a night guard works. So let's say if you have a bite discrepancy and you're touching on one tooth or not touching on others and your jaw is in a lot of pain, they'll give you a kind of a splint that they adjust the occlusion of the splint so that the bite is perfectly even. And that's how they pretty much resolve the pain and get the TMJ under control.
And so are you guys dishing out an equal number of expanders to these?
No.
The expanders are more rare, huh?
Very rare. Yeah, man. It's probably like a tenth.
Yeah, right. Because that requires a lot more skill to implement.
Yeah, it does.
Doctors are more reluctant to use those.
Yep. Especially with that unfortunate, lawsuit and stuff that happened with that appliance recently. So that was an unfortunate thing kind of for the entire orthodontal space. But yeah.
Really?
Yeah.
Even though that appliance, so we're talking about the AGGA lawsuit now.
Yeah.
So, but that appliance is nothing like the expanders that you guys use.
Yeah, but it cast a dark shadow on the whole thing, right? I mean, you've got clinicians already who are so timid to get started. And then you have something like this happen. And then now they're just more scared.
Fuck, man, the irony of that.
Yeah. It is a huge, the whole thing is an irony actually, but
collective punishment.
Yeah.
It's just, oh my God, that makes me hate the AGGA people even more.
Yeah, it's pretty frustrating.
Because not only did they fuck over their patients, they're fucking over the whole industry. of expansion, because all expansion is being clumped together as dangerous now. And people are too dumb to understand the difference between tooth-borne and bone-borne expansion.
Yes. Yep.
Oh, that's incredibly upsetting. That had not occurred to me that that was going to be fallout from this.
Yeah, I mean, even a clinician starting on an oral appliance, man, it can be really scary for them because when a practice transitions into just a dental practice to now addressing an airway issue, they're billing, medical insurance, which is really not much different, but they freak out. They think that their whole practice is has to entirely change, right? Which it really doesn't, but it can be really, really difficult for them to get started. And then you even look at throwing an expander in there, which is definitely you need a much higher level of understanding because they should be then doing some level of ortho in their practice. So yeah, I mean, it's unfortunate, but it is what it is.
Yeah. And so um, your ApnoMed appliance, see, I generally frame splints as a Band-Aid, in that the better thing for a patient to do is to get the permanent fix via
100%.
expansion and corrective orthodontics. But
Yes.
that's just not going to happen because there's a dearth of practitioners that are even capable of executing the expansion.
Yeah, the ApnoDent, any oral appliance is a Band-Aid solution like a CPAP, right? But that's kind of where the Apno TX comes in, which I think you kind of there was a misunderstanding with I think one of your people on the podcast. They didn't understand what was the difference. So the Apno TX is a variation of the ApnoDent. They can actually be used like on active orthodontic treatment. It is not meant to do any type of expansion at all. It's not a removable expander, but what it does do is actually follow the moving teeth. So, like, let's say, as an example, in my dad's practice, a patient comes in, they've got severe TMJ issues, they're in a lot of pain, but they also have an airway issue. If you look at a patient in pain, who has just been suffering for 5 years. They've got chronic migraines. They get locked jaw. They've got ringing in their ears. They're like borderline suicidal, right? Which we see in our office
I
on a
talk to
week.
these people all the time. They're afraid to go into expansion because they're afraid to let go of their splint.
Yes.
The
Okay.
splint is the only thing keeping them going.
Exactly. But I don't blame them because they've been in years of pain, right? So let's say in our practice, what happens is he puts him on an Apno TX for, let's say, 2-3 months. Why? To get the pain under control, man. Let that patient not be suicidal for 3-4 months before you send them down another path of pain, right? Because it is painful. When you go down an MSC or any ortho treatment, it is freaking uncomfortable. Shit's moving, especially if you're putting TADs in, you're expanding, it can hurt. So they'll be on the Apno TX for 2, 3, 4 months, depending on the severity, get the joint under control, that it's not hurting. Then he'll introduce the expander, right? And then once the expansion's done, he'll put him on aligners. But through the whole time, they're wearing the Apno TX because it gives them what? It's nighttime relief. When they bite down in it at night, like you said, patients are afraid to ditch their splint. Well, guess what? They don't have to because at nighttime, they can still wear that splint on their expander, on their Invisalign, so they can get that nighttime relief. But yeah.
So an Apno TX is basically an ApnoMed that goes with the flow of expansion.
100%. Yeah, there's another appliance called the ASA, the Aligner Sleep Appliance. It's invented by Dr. Rob Weiss and Dr. Payam Itai. I'm very good friends with both of them. They work very closely with us. It's a very similar type of appliance. It can fit over the aligners. And I think there might be one other appliance that does it, and I'm not really sure what it's called. But I know that it has a lot of issues with breakages and whatnot. But I would say Apno TX and the ASA Aligner Sleep Appliance are really the only two appliances out there that can be on a used as a like you coined it, go with the flow appliance. The ASA, you cannot adjust the occlusion of it, so it's not really used for TMJ patients. That's kind of where the Apno TX comes in.
Even the ApnoMed can adjust for the occlusion, right? That's kind of
Yes,
what makes it
the base
special.
one. Yes, the base Apno Dent, it will act as a TMJ splint. It's just not a go with the flow appliance. right? Because it's a custom molded to the upper teeth. So obviously, if you're changing trays or an ortho treatment, that appliance is not going to fit next week. Whereas with the Apno TX, you give it to them day one of treatment, and it still works to day zero of the end of treatment. I mean, and then if that patient still has an airway discrepancy or just likes wearing the appliance, they can still continue to wear it as like a permanent retainer night guard.
Is my understanding correct that the ApnoMed and the Apno TX both, even the ApnoMed has an adjustment screw on it that allows it to be tweaked till the perfect bite is found? It's not
Yes.
just like a mold is taken, an
No.
appliance is printed, and then you better hope you got it right because that's what you have. It's
No,
not
no,
like that, right?
absolutely not. No, 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 no. It's not like that at all. You can bring the mandible forward up to 11 or 12 millimeters forward, and then the clinician can literally manipulate the acrylic in the office by shaving it off and making it fit in. If it needs some micro precision stuff, and if it's still, let's say they burr it too much or they take too much acrylic out, they just send it back to the lab and they can reline the appliance and then they can start from scratch. Yeah. So it's not like you get it and then that's it. It is very customizable chairside.
And because there's no headgear effect, can a patient wear an ApnoMed for years?
Years. I think my dad has been wearing his for damn near over a decade now, and we have patients that are close to the 10-year mark, like way before we commercialized it, because he's been using, I think the earliest variation of the appliance that he used in his practice is like over 10 years old, that patients were using it as a splint, not an oral appliance for sleep apnea, but it was the same general concept. And I mean, no bite change. So they can continue to wear it as a long-term management appliance with no problems.
Yeah. Can you say a little bit more about how that bar works to give the body that biofeedback to tell it to hold the jaw forward? Or are we entering into like privacy?
No, absolutely not. No. So it's pretty much what we call it is a mechanosensory activation, which is it's really a tactile response. I think the best analogy that my dad likes to use that really makes sense is a horse. When you go horseback riding, right? You've got 1,000-pound animal. You're not grabbing this horse by the freaking head and turning it, right? No matter how strong you are, it's just not going to work out. The way that you control that animal is the horse bites down on a bit, right? And then it's got reins attached to that bit. Just the slightest touch of that rein, you're controlling that animal to do whatever you want it to do. And guess where that bit is contacting is on the teeth, which is one of the most sensitive tactile response we have in the human body. So it's the same concept in our oral appliances. So that bar, when it touches the lower dentition, which is the most sensitive teeth that we have, that signals to the brain to let's keep the mandible forward in that forward resting posture, bite down on the appliance, bring the tongue to the top of the appliance to promote a proper tongue resting posture. So we're not really, if you look at like an Emma or a dorsal, they pretty much will like jackknife you into that forward stuck position, which is what's causing that pain and side effects over years of use. Now, I'm not saying every person on an oral device will get side effects. That's just not true. There's many good providers out there that can manage a patient long-term if they're very careful and precise and don't over advance on any appliance out there with minimal to no side effects. But there is typically some side effect if you're talking about prolonged use. It's just basic mechanics, right? It's leverage based. So if you look at a tooth-borne leverage based appliance that's anchoring on the upper teeth to bring this forward, you're pushing on this to pull this forward. It's just a matter of time before teeth start to move.
Yeah, Newton's third law.
Yes, exactly.
Speaking of that, right? Speaking of that, it makes me think of the face mask and how. Give me a second. When people wear this face mask,
yep,
they're putting an elastic from here to the MSE.
Yes.
And then the force is pushing the lower jaw back to pull the upper jaw forward.
Yes.
So it's the same idea with your typical sleep splint that people are getting. The maxilla is being pulled back in order to draw the mandible forward. With the face mask, it's the opposite.
Yeah, so you're literally getting the opposite of what you want with that face mask, right? So
Right.
you're getting headgear effect, which is, do you remember like everybody was in freaking headgear when we were in high school? I don't know if you ever.
I don't remember anyone being in headgear when I was in high school. Maybe that was just something about my area. I don't know.
Yeah, I mean, I had multiple friends who were in headgear, right? They would have to sleep with the headgear thing on. Nobody does that anymore because it's like literally outlawed. If your public service announcement, if your provider recommends a headgear, run out of that office, right? Because they've been living under a rock. But nobody uses headgear anymore. They just use the face masks, which is promoting the proper growth.
It's a reverse pull headgear.
Reverse pull headgear.
So
Yep.
you're saying don't use the retractive headgear, but reverse.
Nothing, dude. Nothing retractable. I mean, it should be a common sense now. You don't want to push anything back. We want forward.
Yeah. Yeah. I think it's insane that even some orthodontic surgeons cut people and pull them back.
Yeah, I mean,
That blows my mind, man.
yeah.
Could you imagine going through the suffering of oral surgery only to become smaller?
We see it a lot in our office, man. Unfortunately, it happens more than
That's
you
going to
think.
be the lowest of the low in this space, right? To get orthodontic surgery for retraction. Does it get
I
worse than that?
I don't think it can. Extractions, I think, is pretty bad, but I mean that's worse because you're doing a surgical procedure to then be worse than you already were. So,
Yeah.
and not to mention looking worse. So
Yeah, yeah. AGGA is pretty bad too. I often describe AGGA as a prolonged, very expensive extraction of the upper front teeth.
yeah,
What are your dad's thoughts on AGGA?
I'm gonna leave that one to him. I don't,
Okay.
because of my involvement as a CEO of ApnoMed, I'd rather not, talk about other appliances. I'm obviously biased, right, to our
Yeah.
appliance. I
Yeah,
don't
yeah.
want to badmouth. I think that all of these, Ron, they're tools.
Yeah.
I can use a Phillips head for, a flathead screw. It's not going to fucking work, right? These are all tools that we have. Some tools are better than other tools, and it's a matter of that clinician's understanding of that tool, how it's meant to be used, and if it's going to work right. I'm sure there's some clown out there who can absolutely botch a case with one of our expanders or appliances.
Yeah.
That's like saying, selling a Ferrari to a guy who doesn't know how to drive it and saying this car drives like shit. No,
Yeah.
the car is a masterpiece. You're a shitty driver, right?
Yeah.
So yeah. I mean,
I think the problem with AGGA, and since I'm not a
yeah,
appliance provider, I can speak.
yeah.
I think the problem with it is that it's the sales around it. People are selling it as X, but it's actually Y. Sure, it's a tool. Sure, maybe in theory, AGGA can be used to carefully push the front teeth forward in a safe and predictable way, carefully, right? But it's being sold as this epigenetic expander that triggers real organic bone growth in the face, and it's just not. The sales pitch causes the provider to abuse it and to misuse it. That's the problem.
It is the problem. That one I can agree with you there. And there's a similar one to that is Vivos. I think is a lot of people are kind of it's coming out of the woodwork now. Are you familiar with Vivos?
Yeah, the DNA.
The DNA. It's the removable expander type of deal, right?
Yeah.
So we see so many cases that are botched Vivos cases. We have a lot of providers who paid $50,000-$60,000 to become a Vivos provider, and they've had a patient in treatment for a couple years, and it's just getting worse, or they just flared the teeth out. But I think the problem is it is the tactic of what they're selling. I think that is what makes me kind of upset. Right. I think the way that they do it, it's put it in everybody's mouth and it's just going to work and blah, blah, blah. And it's just really not the case. I think even there's something to be said there, Ron, about just traditional MSE. I think that my belief is that an extreme of anything is not great. Right. I like to be pretty neutral, open-minded. You've got, even politically extremes I'm not a fan of. But let's look at expansion. You've got this side, which is no expansion, and you've got this side, which is let's expand everybody. I think this end, Ron, I think we're getting kind of into an interesting territory where we're going to start to see some cases come out or some literature and stuff that I think it's not great. I think that when you're doing an expansion, that's some serious shit that you're doing. It's not rocket science, But when you're talking about skeletal expansion, that can have a serious consequence. And if you just have a patient in your chair and you're throwing an expander in there, expanding them, and you're not really looking at the joint, you're not looking at other problems, man, good luck. I mean,
Mm.
that's why my dad's case reports and his consult exams are so extensive. And that's why we've even had some of your viewers that they come in and they're mad that he won't just start him on expansion. They're like,
I know.
I want expansion tomorrow. And he's like, no, that's not how it works, right? We're going to start with the least invasive, and if we need to go there, we're going to go there. But I think doctors need to be very, very careful, and I think patients need to be more careful that if they just go to an appointment, and a doctor's like, we're going to expand you, I think there needs to be a very valid basis on why that expansion needs to happen, and it needs to be very calculated.
Yeah. I mean, I'm of the opinion that, just spitballing a number, 80% of Americans could benefit from skeletal expansion.
Yeah,
But that doesn't mean that 80% of Americans should cram into every doctor's office who's offering MSE and hope for the best.
absolutely.
I think that what I would be interested in hearing, would you say that a large number of Americans would benefit from a well executed skeletal expander, but it's just that the execution is where we're failing?
I think so. I think if we're talking about 18 and older, so adults, I,
Yeah.
I do think that, yes, I think a majority of them could benefit from some sort of an expansion. Not only is it going to alleviate their oral box cavity, more room, functional orthodontics, a better bite, also the upper airway, nasal constriction. I'm sure you experienced probably better nasal breathing after your expansion, did you not?
Way better.
Okay.
Way
That was
better.
my wife's number one thing that she tells people. It was worth it just for the nasal breathing
My
because she
same
had,
thing.
if you look at, she was a chronic mouth breather growing up, super tiny arches. Right. So those were all reasons because she couldn't breathe through here. You should never breathe through your mouth. Never. Right. If you mouth breathers, they always have these other list of complexities that ties into what we're talking about. But that was her number one thing is when this popped and it started to expand, she literally was like, holy shit. It's like a wind turbine. Like I can actually breathe. So yeah, it has a multi-purpose use. And I do think 70 to 80% majority of US adults could benefit from some sort of an expansion.
Hmm.
Maybe not always needs to be a skeletal. Sometimes it can be done with a dental, but most likely, I would say skeletal.
Yeah. What are you seeing as the big failures of MSC execution by a green newbie MSC provider who is just throwing it in and blowing faces up with it?
Man, I mean, I think the asymmetry is a big one. You talk about that a lot.
Yeah.
I think asymmetry is a huge problem because they don't properly understand, I think, what's going on, which sucks because that clinician had a very good, they had a good, what's the word I'm looking for? Motive.
Intention.
Intention. Their intentions were to help,
Yeah.
but I just don't think they had the proper readiness or understanding to do it. So controlling the asymmetry is huge. Part of that, I think, does come down to the type of expander being used. I think another one is, how much are we expanding? And I think the other one is the mandible. People are neglecting what to do with the mandible. I know it's a controversial topic. I'm not going to dive into it. But I think that a lot of people do this and then they totally forget about the mandible. And I think it's how can you kind of take care of this without addressing this? It's a functional thing, right? They close together. The joint, everything is one. So I think that's another issue that I think we're still not there yet in the industry because I don't know how many people even do anything with the mandible at this
They
point.
they don't, man. They just throw some bubble gum and scotch tape on it and
Yeah,
hope it comes together. But I
yeah,
think it's a obvious um, shortcoming in the space is that people are doing these radical maxillary expansions of 6 to 10 millimeters without doing skeletal expansion on the mandible to complement it, and it's resulting in obvious uh, reduction in facial harmony. I mean, you can have someone who looks better with two narrow jaws than they do with one expanded jaw and
yeah.
one narrow
Oh
jaw.
yeah. I'm with you there, man. I think that can look so bad, and I've seen it. It does not look good.
Yeah. And let's be honest, a lot of people in this space are looking for a cosmetic improvement because small jaws are not as beautiful as big jaws, and then they get blindsided by this balloon face aesthetic that they end up with. And then 99% of MSE cases happening in America are being finished with dental expansion of the mandible.
Yeah.
And then you ask them about, MSDO, and they say, my TMJ problems. We got to be careful about expanding the mandible. And maybe there's something to that. Maybe expanding the mandible is even riskier and more delicate than expanding the maxilla with regards to potential joint side effects.
Right.
And so if 9 out of 10 dentists are too scared to use an MSE, then maybe 19 out of 20 are going to be too scared to use a mandibular expander. I don't know.
Yeah, I mean, I'm going to tell you right now, I think we're like 15 years, 20 years behind on the mandible expansion, right? I mean, I don't know when we're going to get to the point where it's like MSC, which is great. I think it's great that a lot of clinicians are doing it now. I think we need to proceed with caution. I think it's awesome, but I don't know when the plan for the mandible is going to catch on. I mean, I don't know how it can be a neglected part of the treatment. I don't understand
why. Why is it neglected? Because it always requires a surgical intervention to cut.
I think it's anything that's difficult. I think has pushback. Right now, you've got these clinicians who they feel comfortable with the upper. They can expand, freaking great. They can expand at 12 millimeters any day of the week. Now they're comfortable. They're making money. They're getting expansion. But now they're like, I don't want to now dive into that freaking can of worms of the mandible. I already figured out the upper. I don't need to do it. So I think that's part of it. They're making good money doing it, and it's working. Maybe it's not the most efficient, or it's going to have long lasting effects. But I don't know. It's hard to say.
Yeah, they're going halfway basically.
Yeah, but
it's getting halfway up the mountain, and they're looking out at the view, and they're like, "Wow, this is an incredible view." But really,
yes.
If they were to just ascend the final peak.
Yeah.
Be like, oh my God, this is really it.
Yeah, but I think that when you do throw in anything with the mandible, it is more calculated. It can have more of a risk, especially with the joint. So I think it's another layer of complexity, which I just don't think the education is there yet. Doctors don't know enough.
You know what I think we need more of in this space is doctors who are willing to charge a higher price and to reduce their volume. I talk to a lot of people that are willing to pay a premium for the right treatment. They would be willing to pay triple of what they pay for your typical MSE plus Invisalign treatment, which, let's just spitball. Let's say that's $15,000. What I've gathered is that here on the East Coast, it's significantly less than it is on the West Coast. It's like 12, and then it goes to 24, or 15 to 25 on the West Coast, 7 to 12 on the East Coast. But I think doctors could be charging 30. But in doing half the patients, but doing them right, and people would be willing to pay. What are your thoughts on that? Am I way out of line here?
No, I think this is another can of worms. I don't understand how somebody's willing to pay, I don't know, $15,000 for a nose job, but they're not willing to pay $15,000 to frickin' correct their health. I don't get it. It doesn't make sense to me. I think even $15,000, $20,000 is a complete steal for a proper expansion and treatment. It's a freaking steal.
That's going to change, man. It's going to change.
People pay. If you look at, are you familiar with Inspire, the surgical implant for? That is so expensive, and
it's an electrical stimulator that opens up your airway.
Right? Yeah, it pretty much jets your tongue forward when you have an apneic episode. But people pay so much money for that. Why wouldn't you pay the same amount to fix it for life and not have a freaking pacemaker zappy thing in your chest, right? Like, I don't know why, but it's in my dad's office, man, every day. People fighting. Why is it so expensive? There's a guy offering, for $8,000, $9,000, and all my dad can say is, you go there. You'll be back in a couple of years, probably, or, Godspeed. But I think the problem is, dental school. They teach students to be businessmen, how to run multi-center practices and increase profitability. What's your chair side turnover? What's your dollar per hour on your chair? How much are you making per customer, right? This is what I think, unfortunately, majority of dentists get in the game for.
Mm.
So if you're trying to tell those guys, to cut back on the volume and then increase your prices and this and that, I think that it's another movement that is just not happening. But it is damn near impossible to deliver this quality of care if you're seeing 100 patients a day. It's
For
not
sure.
going to happen. There's no way it's going to happen. And if it does happen, good luck, because I don't know what kind of treatment you're getting, because there's no way that the ortho is mediating your treatment. It's impossible,
Yeah.
right?
Yeah. 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 We're reaching.
How many patients I talk to who have gone through multiple rounds of ortho and have only seen their orthodontist 3 times? What? That should be a crime, man. That ortho should be put in jail. They
Mhm.
just have assistants doing all of the care, right? I mean, and then they're playing golf. So
Yeah. Yeah, man. You want to talk about how I make a living in this space? We were talking about that a little bit offline before we started. The reason people pay me to talk is because they feel like they're not getting enough attention from their doctor. They
yeah,
just want someone to talk to. Dude, a lot of what I do is just listen. I just listen and then I coach people about how to go back and talk to their doctor about what they want.
right.
It's a huge problem. Doctors seeing 30, 40, 50, whatever patients a day, and individual patients feeling like they're not being seen.
Yeah, I think that's almost the case that we were talking about. I think this was before we started. Is my dad's practice is patients, they get so happy because he actually listens and
Yeah.
doesn't tell them they're crazy. They're patients who have been tossed around. They've had multiple rounds of ortho. They're in pain. They've been told it's in their head. They're overthinking it. They've been placed on anxiety medications and a bunch of medications, and then he's the one who tells them that no, you're not crazy. This is your problem, and I suspect this is what you have. And when a doctor tells you that, because I've had medical issues and stuff, and when I finally found the doctor who told me that I'm not a lunatic, man, it felt so good.
Mm.
So I think that's another thing, man. It's clinicians aren't willing to listen. They don't want to take the time to really listen to patients, or they don't want to take the time to kind of understand what's really going on. They don't want to start at the foundation. They just want to change the siding of the house and the windows and do a freaking quick flip, right? But nobody wants to look at, is the foundation cracked? Is the house settling? And start there. So I think
Yeah.
that's kind of his approach and why he's so successful in his cases.
Yeah. 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 Your dad must be having a hard time taking new patients. Am I right about that or wrong about that?
In what sense you mean capacity wise, like
Yeah.
accepting the cases?
Yeah.
I would say that yes and no. I know that it's he's, I think, practices 3 days a week right now. He sees patients on Thursdays. He does consults, exams. Fridays is writing books and working on ApnoMed, and in between that, he's always working. But it's a weird, interesting bottleneck in his practice, and with any practice who specializes in this, because you can't be a volume practice, right? So you have to charge a certain amount to pay the bills and make money. But the amount of patients who are willing to pay that for what you need, it's like an interesting price elasticity. Like it's a hard balance to find. And I do truly think there's a bottleneck. Like there's a flat line of these MSC providers and how much they can make and how much quality of care. I'm talking about good MSC providers, not ones that are running factories, right? They're actually conducting treatment. Unless they're, I think they should be charging 30, 40 grand for these complex cases, but they're not. They're charging under 20 grand most of the time, under 15 grand. So it's hard because you can't see 100 patients a day. You can't charge $30,000 a case. It's
Right.
hard. It's a hard
Right.
nut.
Yeah. So there's got to be some. There's. I think that. So my channel right now is at what 20,000 subscribers. Let's say my channel is a indicator of awareness of this space and
Right.
demand for doctors like your dad. My channel doubled over the past 3 months.
Yeah, I joined your channel, I think, when you were at like 7,000 subs.
Right. That's what I had when I interviewed your dad,
Yeah,
probably 7 or 8
yeah,
thousand.
it was.
So let's say 2 years from now, I'm at 50 or 100,000. What is that going to mean for the demand on guys like your dad or Dr. Lipkin or the top tier people who I feel comfortable
Yeah,
referring patients to?
I don't know, man. I really don't know. That's why I keep telling my dad he needs to find an associates and start training them so
Yeah.
that he's getting older. My dad's 65, I think turning 66. He can't be doing this forever. And what's in his brain is so precious. With Dr. Lipkin, Dr. Moon, all of these guys. So, they need to start training people to do what their craft is, so that when they're not around anymore, people can keep spreading the word. But I think it's a crisis for sure. It's a big crisis.
It's a huge crisis. And I hope to God that wish that you just expressed is answered, because man, I fear it might not be, just because so many young dentists are coming in strapped with debt and unable to really experiment and try these new ways of practicing.
Yeah, man. I mean, I think you said it better than I could have ever said it. How could you convince dentists fresh out of dental school, which is the ideal candidate? Because you want to start with somebody who hasn't been corrupted with all of the other crap out there, who they've been sold or used in their office. You need somebody green, who's fresh out of school, who's the least corrupted, they're very malleable. You can train them, but they're graduating with hundreds of thousands of dollars in school debt, and they're taught to open up a practice that's going to make them a ton of money. How do you convince that person to not go down this difficult path? Man, I don't know, dude. It's really hard.
Yeah. Dr. Lipkin has a young orthodontist working with him. I forget his name. It might be Dr. Kim. Young guy, and man, when he watches over Dr. Lipkin's shoulder any chance he can get, he doesn't say much, but he watches and he learns. Like, that guy is just trying to soak it up. So I think, we need more of that. We need masters like your dad to have apprentices who are thirsty to be apprentices and to learn the craft.
Yeah, but I think it needs to be somebody who's really in it for the bigger picture, because otherwise it's not gonna happen. Right? There's no way. But if you find an ortho who's looking to learn, please send them our way, because it would be great to find some young doctor who's very eager to really master this craft for the next generation.
Yeah. Would your dad train a general dentist, or would it have to be an ortho?
It would have to be an ortho for sure.
Yeah. Damn. That's a bottleneck too.
It is a huge bottleneck.
Yeah,
absolutely. But I mean, yeah, man, I think that we covered a lot. I mean, it's I think what you're understanding, I think a lot of your viewers are understanding, is that this is a huge, complex problem. There are so many layers to it, right? Like, I went through the whole freaking thing. The only reason I'm here talking to you about this is because of my dad, and he identified my airway issues at a young age, and he resolved it. But I would have been another one of those kids who I was stamped with learning disability. I was prescribed Adderalls. I was told college isn't an option. There's so many young men out there, man, that are put in this boat, and young women who they think they're stupid. They're told that they're not scoring good on exams. They're disruptive in class, right? How do you expect a young kid to pay attention in class when they're freaking gasping for air all night? It's just not going to happen. And in those years of development, right, under 16, 18 years old, the hormone production that's going on for cognitive development, physical development. And we know now that pediatric apnea is way more big of an issue than adult apnea.
Oh my God.
Dude, I mean, so it's frustrating, because now we're just getting to adults. And then you've got pediatrics, which is the best time to address it, because you don't even need to do, skeletal style for invasive stuff. Just put them in the right opportunity to develop their jaws, and they'll be fine, right? At a young age. We have patients 3, 4 years old, 5 years old, that we now see them in their teen years. Man, their jaws are beautiful. They don't need expansion.
What do you basically do for them, like, in a nutshell?
I mean, I think that's what I believe my dad wanted to talk about on the next talk, because you haven't really covered much of early pediatric airway, which, man, you're going to be blown. I mean, that's a whole nother science of itself and treatment modality, but it's pretty much like giving them a functional type appliance that will promote their mandibles to grow. Like, we have a variation of our appliance called the ApnoTeen. It's a type 1 FDA cleared. It's a functional appliance, not advertised as a sleep apnea appliance or TMJ appliance. But that one is purely used to just promote proper mandible growth, bring the jaws forward, tongue posture. You've got these kids with scalloping tongues because their tongue has nowhere to go in their tiny arch, like my wife had, right? And they're going to need full-blown expansion or surgery when they grow up. But if you teach that kid proper myofunctional resting posture, right? Tongue ties, man. Myofunctional therapies are underrated as hell.
Mm-hmm.
Those should be the people who are you taking your, if your kid has a tongue tie, speech issues, take him to a myofunctional therapist. They will set you down the right path for your kid. Release tongues. If you've got a tied tongue, how the hell are they supposed to put it on their palate to support their broad arch? It's not going to happen.
Does
They
your
can't
dad do that?
He doesn't do the release himself. No, Dr. Henry Roshan, that's right down our in our building, does all of the releases. But that's the number one thing. We don't even put a patient in appliance therapy as an adult if they have a tongue tie, because they can't get their tongue above the appliance.
Wow.
I mean, dude, I'm telling you that it's like you're frustrated. Think how I'm like super frustrated because I work in this space. I see it every day. It's very frustrating. Start as young as you can, man. I was one of those kids. I didn't have the technologies we have now, so I had a jaw surgery, but my whole life flipped upside down. They told me I should look at alternative career paths because I would not be able to go to college. I went to college and got my master's, and now I'm doing this amazing thing with my dad. So to those people, who told me I can't do it and tell kids every day they can't do it, go to hell, because you have no idea what you're talking about, to be frank.
So if your airway was never fixed, you wouldn't be where you are now.
No, dude, I was like 50 pounds overweight. I was failing every single class. I couldn't stay awake. I dropped out of sports. I was pretty depressed about how I looked. Kids were getting big and strong and, getting girls, and I was getting fatter and weaker and stupid.
Yeah. You've got a beautiful smile now. I'm sure it didn't look like that before your dad put his hands on it.
I know a good ortho. But yeah, man. I remember the day that they brought my parents in. The school counselor brought my parents in, and they were like, Ryan's failing, all of his classes. It's, we're looking at college applications. We don't think he's a right fit. We need to put him in the special ed program. They had falsely diagnosed me with ADD. They prescribed me Adderall. And I remember, man, my dad's face turned bright red, and he freaked out, and he walked out of their office. And then that really, set him down the pediatric realm, right? Because back then we knew adults had airway issues, but we didn't really know pediatrics could have them too, and how exaggerated it was in kids that are developing cognitively and physically. So he had me take a sleep test. I got diagnosed. He waited for the right age for me to have oral surgery, got it done. And I'll tell you, man, it was like a butterfly hatching from a cocoon. Like everything. I immediately dropped over 40 pounds. I started wrestling again in high school. I went to college. I got into weightlifting. Now I compete in powerlifting. Like all of these things that I was told I couldn't do. I couldn't play sports. I couldn't play football because I was too slow and weak. It was all airway issues. I couldn't breathe at night. How do you expect a kid to grow when they can't breathe? So,
oh man, what a testimony! What a testimony!
Yeah, I mean, that's the only reason I'm really so passionate about this, is because my experience with it and how nasty it can be. I'm sure. So what set you down your path?
Chronic headaches.
Okay.
Yeah, I got my first headache my freshman year in high school, the year after I took my braces off. The headaches got progressively worse for the next 8 years when I went through high school and college, after I had 8 extractions and braces.
Right.
And then by 2012, the year I graduated college, 8 years after I finished my childhood ortho, I was having headaches constantly. I tried everything under the sun to make them go away, using traditional medicine, holistic medicine, alternative therapies, physical therapy, diet, nutrition, posture work. Fast forward to 2014, 2 years later, I realized there was something off about my bite. When I was living in a Buddhist monastery, meditating several hours a day, just experimenting with different ways of positioning my mouth and my tongue. I was like, something's not right there. Did some Googling. I'm a pretty good Googler. That's one thing I got from my $200,000 college education, is I know how to find
Google.
Yeah.
Right? Isn't that funny how that works?
It's an incredibly important skill, man, and I really think that's what separates boomers from the younger generations is
Yeah.
the younger people know how to Google, the older people don't. I Googled in 2014 about weird stuff happening in the mouth, came upon mewing, found Dr. Bill Hang, met Dr. Bill Hang in 2014, 9 years ago. He proposed a $14,000 treatment plan to me back then to open up extraction spaces. I was living in a tent at the time, wasn't an option for me. For the next 2 years, I tried mewing my mouth bigger as I became aware of the fact that maybe my mouth is too small and maybe that's why I'm waking up with headaches is because of this Airway, TMJ, weird hybrid problem.
Right.
2 years later, I had gotten nowhere with mewing. I found a cheap knockoff version of Dr. Hang's treatment for 9 grand. Basically, some guy who just gave me these junky plastic sagittal expanders.
Mhm.
That failed, and I basically snowballed then through several orthodontic treatments as one doctor would say, oh, that's a shitty way to deal with this problem. Why don't you do AGGA? Oh, AGGA is a shitty way to deal with this problem. Why don't you do this? And then eventually MSE, and now trying to pull it all back together after all that is pretty much my story in a nutshell. Chronic headaches.
So, were you ever diagnosed with TMJ issues at all?
No.
Huh. Interesting.
Probably false negative on that. I probably do have TMJ issues. But I don't have
Interesting.
any pain in my joints. I don't have any acute pain there.
Right.
After my
Interesting.
MSE in the large expansion I got, I started having some weirdness in one of my joints because my
Right.
bite was so disrupted. But that's fixed now after a couple of years of corrective orthodontics, trying to
Yeah.
pull it all back together.
The TMJ issues are really interesting, man, because like we see a lot of, not a lot, but some patients who they you can see there's signs of wear and tear on the joint. They've clearly got a joint issue like clicking and popping, but the chief complaint of pain isn't there yet. So
Mm-hmm.
it's a very interesting beast in its own, and typically that will present itself in the early or later years in life. Especially if they get osteoporosis and arthritis, is when that type of pain will present itself. But yeah, that's really interesting. But I mean, I wonder how many people like you have gone down this journey of self, right? Because I had my dad that took everything over, but you kind of did it all on your own,
Yeah, and
right?
that's where JawHacks came from. JawHacks is basically me um, telling people about my mistakes and
Right.
hoping that they don't make the same mistakes that I did.
Well,
That's pretty
I
much
think
it.
that it's a fantastic thing that you've got going on, and I know that it's helping a lot of people. I read the comments, I watch the videos. I'm a big fan,
Thank you,
so
man. I
I
really appreciate it.
subscribe. I have the bell icon on and all of that. So when you drop a video, I'm watching it right away. So I think
Yeah,
that you say that we need more orthodontists, like these pioneers in the expansion. I think we need more Rons, evangelists, who are really exposing the dirty truth of dental, ortho, medical, even, man. So props to you for doing it. I know it's not easy. I'm sure you've got haters. I know we talked about a troll you had, but you got to do it. Good for
yeah.
you.
I appreciate that, man. And I did apply and get accepted to dental school. I didn't end up going, but
Yes.
interestingly, not being in the profession has given me the liberty to speak more openly about this stuff. Could you imagine me doing some of the videos I do with $500,000 of debt and hoping that I'm not uh, having my dental license stripped away for making some inappropriate comment? I couldn't do it.
Isn't that interesting how that works? Like because I was pre-dental in college for a couple years, my undergrad, and like I was dead set on it. But I look back on it and I'm like, man, that would have been the biggest mistake of my life because you and I can touch so many more people's lives than we could have being busy trying to keep a practice running and get rid of $500,000 in debt.
Mm,
So I think everything happens for a reason. But yeah, I mean, I don't think that this would even be a thing if you went to dental school. You'd be
yeah.
worried about a whole other host of problems right now.
Oh, big time. Now I'm worried about YouTube and saying the wrong thing and getting hit by YouTube, but
Yeah.
at least I don't have to worry about the ADA
Yeah.
taking my license away.
Yep. Exactly. 100%. I was going to say one other thing was Oh shoot! It totally slipped my mind. It was really important too.
Yeah, that's okay. I'm sure you'll think of it. You know.
Uh, it was had to do with the dental school.
Yeah.
Whatever.
Was it about the cost? Was it about
No, no, I totally forget. But anyways, doesn't really
yeah.
matter. I'm sure
Yeah,
I'll
that's
think of
okay,
it.
man. Well, look, I think we've pretty much reached. We've gone what, an hour and a half. That's the
Yeah,
perfect amount of time. Why don't we end it here? Just a little bit of foreshadowing. I am going to be doing another interview with your dad in June.
with better
So
audio.
with with better audio and perhaps with an emphasis on the pediatric side.
Yeah, I think that would be huge.
And I think that's going to be dope. And then one favor I want to ask of you is, one goal I have for this channel for 2023 is to learn more about orthodontic surgery and about helping patients navigate that space. So
Yes,
if you have a surgeon that you think would be willing to come on, then maybe you and I can connect in private about that, and you can help get me a surgeon to interview on the JawCast series.
done, done, and done. I've
All right.
got I've got a couple I can pick from. So why don't you email me and then we'll talk about that. But I think that's a very good idea. And then I don't know, have you had any myofunctional therapists on?
I have not.
Okay, I think we need to do that too. That's going to be a big one because it's very underlooked.
Okay.
Myofunctional therapist and oral surgeon. I also have a lot of those that we can pick from. So why don't we talk about that?
Dope, man. That sounds good. That sounds good. I appreciate your willingness to help me out.
Absolutely, Ron. Thanks for having me on. It's always fun talking to you, and keep doing what you're doing, man. I appreciate it.
I appreciate that, man. And you too. Keep helping out your dad, help out so many other people.
Absolutely. Take care, Ron. Talk to you later.
All right. See you later, Ryan.